everyone. Thank you, Dr. Chandragowda. And are my slides visible?
Yes, ma'am.
Yes?
Yes, ma'am, they're visible.
Okay, great. So the topic of my talk, it's sponsored by AstraZeneca, is Evolving Treatment Landscape in First-Line Metastatic CRPC. And we know that even though it's in castration-resistant phase, the androgen receptor pathway is still active. And therefore, androgen deprivation therapy continues to be an important component of the treatment for metastatic CRPC. It's also known that when a patient enters the castration-resistant phase, the patient is more likely to die of the prostate cancer rather than any other cause. The metastatic CRPC is lethal. But fortunately, there have been a multitude of FDA-approved treatment options, 6 in the past 1 decade itself, and I'll be discussing those and the ones that are new and upcoming as well. So this is how the treatment landscape for metastatic CRPC has evolved over the years. From 1996, when mitoxantrone had shown some efficacy and was the only chemotherapeutic agent showing the efficacy in prostate cancer, which had spread to other body parts, we have moved on. So this was soon followed by the approval for docetaxel, followed by cabazitaxel. Immunotherapy came in form of sickle T-cell therapy. And then we had some oral agents in form of abiraterone, enzalutamide, some radiopharmaceuticals like radium-223 gaining approval. More recently, we have found a place for immunotherapy, immune checkpoint inhibitors in metastatic CRPC, very impressive role being played by PARP inhibitors, namely olaparib, rucaparib, and a few more, and the lutetium therapy. A combination of some of these agents is what is undergoing active study currently. So broadly, if we have to categorize the treatment options for metastatic CRPC, what are those? So we have agents that interfere with androgenic stimulation of tumor growth, namely 3 agents: enzalutamide, apalutamide, and darolutamide. We have abiraterone, which is an androgen biosynthesis inhibitor. We have chemotherapy with taxanes, namely docetaxel and cabazitaxel. Now, for patients who harbor germline or somatic mutations in the DNA mismatch repair genes or homologous recombination repair genes, PARP inhibitors are an effective option. For patients who express high MSI or express PD-L1, immune checkpoint inhibitors as monotherapy are also an option. For patients who have asymptomatic or minimally symptomatic disease from, say, only bone mets without any visceral disease, can also gain benefit from immunotherapy with sickle T. We have bone-targeted radioisotope radium-223, which is FDA-approved option in patients who have no visceral metastasis. So quite a lot of categories to choose treatment from. But it's important to remember that metastatic CRPC is a lethal disease with median overall survival reported in clinical trials to the tune of 3 years. However, we have all experienced as medical oncologists that in real-world practice, actually the median OS is not that much and is often to the tune of 21 months or so. Now, the 3 landmark trials which established 3 different agents as an important and significant and effective first-line treatment for metastatic CRPC. The first trial was the TAX-327, which established the combination of docetaxel chemo with prednisolone as a better option when compared to mitoxantrone, which was then the standard of care for treatment of these subset of patients. It also proved that 3-weekly schedule of docetaxel was better than the weekly schedule, and either of these did better than mitoxantrone. Subsequently, we had the PREVAIL trial, and that established in patients who were chemotherapy naive, they could benefit from the use of enzalutamide as a single drug in the standard dose of 160 milligrams a day. In this trial, there was improvement in the radiographic progression-free survival and in the overall survival compared to placebo. The third important trial was the abiraterone use in the 302 trial. And this showed that the patients who were again chemotherapy naive, the metastatic CRPC patients, those who were asymptomatic or mildly symptomatic, benefited from the 1000 milligram a day dose of abiraterone acetate. And it's important to remember to always use abiraterone acetate with prednisolone in the dose of 5 mg/d in the metastatic setting. But the bigger question is, how do we choose our first-line treatment? So the factors that I take into consideration while choosing the first-line treatment would include what was the prior systemic therapy used when the patient was castration sensitive? What are the sites of disease involvement? What is the extent of tumor burden? Whether the patient is symptomatic or asymptomatic, and what are the comorbidities? Very important factor to be considered in decision-making. Now, there are no phase 3 trials which have compared enzalutamide with abiraterone till date. However, there are limited data which have compared these two agents in the initial management of patients with metastatic CRPC. And the choice of one agent over the other, however, should depend on the toxicity profiles and the patient-specific factors. So there was this open-label randomized phase 2 crossover trial which was published in 2019 in the Lancet Oncology. What it did was that it studied the sequence of abiraterone followed by enzalutamide, that is group A, and compared it with the reverse sequence of enzalutamide followed by abiraterone. And this open-label phase 2 crossover trial interpreted that enzalutamide showed activity as a second-line novel androgen receptor pathway inhibitor, whereas abiraterone acetate was better when used as first line. There was another indirect meta-estimate which was generated from 4 randomized studies published in prostate in earlier year, 2017. And that had in fact shown that enzalutamide outperforms abiraterone acetate in both pre and post docetaxel setting in terms of not only radiographic progression-free survival and time to PSA progression, but also in terms of PSA response rate. So that question still remains unanswered. So both are an option. We have learned over past 6-7 years that metastatic prostate cancer is actually biologically very heterogeneous. There are multiple pathways that have been identified with genomic alterations in patients in advanced stage prostate cancer, namely the WNT pathway, the PIK3CA pathway, the cell cycle repair mechanisms get affected, and obviously the DNA repair mechanisms do get altered in 1 out of 4 patients with metastatic prostate cancer. So 23% of patients with metastatic CRPC in fact have alterations in the DNA repair mechanisms. And as you would notice in this pie chart, BRCA2 constitute a very significant chunk of these alterations. And there are many more significant ones being the ATM alterations and the alterations in CHEK2 and also BRCA1. So what is the relevance of identifying these HRR gene alterations? So one is that in some of these patients, there could be family history, and therefore it's associated with the personal and familial risk of cancer, not only prostate, but a few more. It serves as a very important prognostic marker for aggressive prostate cancer, and therefore portends a poor outcome with the standard of care treatments. It is also a predictive biomarker for the efficacy of PARP inhibitors. So as was documented in the PROfound trial, a randomized phase 3 trial of olaparib with abiraterone or enzalutamide, wherein the PARP inhibitor, namely olaparib, was found to be more beneficial in those who progressed on abiraterone or enzalutamide and had an alteration in one of the pre-specified 15 HRR genes. So in terms of overall survival, there was significant improvement, and there was also an improvement in the radiographic progression-free survival with the use of olaparib. And similar results were reported with another PARP inhibitor, namely rucaparib. So what are some of the recent updates and what are the trials which are ongoing? And I'll spend some time on these recent updates now. So there are these 5 combination treatment strategies using various combinations of namely androgen receptor signaling inhibitor with say PARP inhibitor, the androgen receptor signaling inhibitor with the immune checkpoint inhibitor, also its combination with chemotherapy. These are being studied. The combination of chemotherapy with immune checkpoint inhibitor is also being researched. And lastly, the immune oncology drug with PARP inhibitors is another area of active ongoing research. So let me start with the combination of androgen receptor signaling inhibitor with PARP inhibitor. And two very interesting papers presented this year in the ASCO GU Symposium 2022. And I'll start with this first one, very relevant and significant one, the PROPEL trial, a phase 3 trial of olaparib and abiraterone acetate versus placebo and abiraterone acetate as first-line therapy for patients with metastatic CRPC. Professor Fed Saad presented this. What was the background and what was the rationale of using this combination? So we all know that the median survival of these patients with metastatic CRPC is approximately 3 years in clinical trial setting and much less in actual clinical practice. And most of these patients, in fact, almost half of these patients end up receiving only one line of active therapy and then they fizzle out. So there's a major unmet need to improve upon the patient outcomes in the first line treatment setting itself. So a phase 3 trial of olaparib monotherapy had earlier demonstrated prolonged radiographic progression-free survival and overall survival. We are aware of this trial. And there was also a phase 2 trial which had shown prolongation of radiographic PFS in patients with metastatic CRPC following docetaxel with the combination of olaparib and abiraterone irrespective of HRR mutation status. So this PROPEL trial is the first phase 3 study to evaluate the combined effect of PARP inhibitor with the next generation hormonal agent, namely abiraterone acetate in first-line metastatic CRPC, irrespective of the HRR mutation status. So the rationale behind the combination is that the PARP inhibition reported to increase the activity of the next generation hormonal agent, namely abiraterone in this trial, via the androgen receptor dependent transcription. The next generation hormone agent is reported to induce the HRR deficiency, thereby increasing the susceptibility to PARP inhibition. So when you use the combination of these two agents, you achieve a combined effect, and actually you achieve anti-tumor activity in both HRR mutant and non-mutant prostate cancer. So this was the basic rationale. PROPEL trial, the first line use in metastatic CRPC, docetaxel use was allowed in the hormone-sensitive prostate cancer stage. No prior abiraterone use was permitted. Other NHA was allowed if had been stopped 12 months or earlier. The patients had to have good performance status. The patients were randomized 1:1 to receive olaparib in the standard dose of 300 milligrams BD and standard dose abiraterone 1 gram a day, and the other arm being placebo with abiraterone acetate. The primary endpoint of PROPEL study was radiographic progression or death by investigator assessment. So the radiographic PFS by investigator assessment, the curve here shows that the hazard ratio was 0.66, meaning thereby that there was 34% risk reduction of progression or death with the use of olaparib with abiraterone. The median radiographic PFS was impressive, 24.8 months versus 16 months with the placebo with abiraterone use. What about the blinded independent central review? There was 39% risk reduction of progression or death with the combination of olaparib with abiraterone, the median radiographic PFS being 27.6 months. The overall survival, the data is immature, and the final results will be eagerly awaited. What about the time to first subsequent therapy or death? There was an improvement in this also. The median time was 25 months versus 20 months in the placebo arm. And the time to second progression or death was also improved, however, not reached in both the arms. The overall response rate wise also, the combination of olaparib with abiraterone performed better to the tune of 10%, 58% overall response rate compared to 48% in the placebo arm. and stable disease, and proportion was similar in the two arms. What about the safety profile? There was only a relatively small increase in the discontinuation for olaparib versus placebo. However, the discontinuation rate for abiraterone was similar in both the treatment arms. What were the most common adverse effects? They were as expected, nothing untoward when the combination was used. So adverse event profile was in fact consistent with the known toxicity profile for olaparib and abiraterone acetate, as is evident from this slide. The quality of life was also assessed in this trial, and it was found to be comparable between the two treatment arms. So to summarize the PROPEL trial, the combination of olaparib with abiraterone did lead to significantly and clinically meaningful improvement in the radiographic PFS in the first-line treatment setting for metastatic CRPC. The benefit was seen irrespective of the HRR mutation status, and future presentations of mature overall survival data and greater analysis of the HRR mutant versus non-mutant subgroups will be important, according to me. The other study, which was again presented this year in the ASCO GU Symposium, was the phase 3 magnitude study, very similar to PROPEL study. It studied the combination of niraparib with abiraterone acetate as first-line treatment, again in metastatic CRPC, with or without homologous recombination repair gene alteration. The only difference was that there was a prospectively selected biomarker cohort designed to test the HRR biomarker. So there was stratification in the beginning itself. It was pre-decided that the patients will be grouped as per their HRR mutation status into positive and negative subgroup. And in fact, in the negative subgroup, there was pre-specified early futility analysis. There was no benefit documented in the HRR biomarker negative patient subset, and the enrollment therefore was stopped in this cohort. However, the benefit was seen in the BRCA mutant subgroup in terms of improvement in the radiographic progression-free survival with the combination of niraparib and abiraterone acetate, both by investigator assessment and also by the central review. There was significantly reduced risk of progression and death. All the pre-specified subgroups seemed to benefit, whether they were HRR biomarker positive as a whole group or those who had BRCA102 mutation positivity. The time to use of subsequent cytotoxic chemotherapy was also increased with the combination of PARP inhibitor with abiraterone acetate, and there was also delay in time to symptomatic progression across gene alterations. The overall survival data, as in PROPEL study, is immature till date, and there was also prolongation of time to PSA progression across gene alterations. So not only BRCA1-2 mutation, but other HRR mutant patients also benefited. The response rate, again, quite similar to PROPEL study, was significantly better with the use of PARP inhibitor with abiraterone acetate with maintained quality of life. So this is important. Moving on to the second combination treatment strategy of androgen receptor signaling inhibitor with immune checkpoint inhibitor, we have this important trial, Keynote 365, with studies pembrolizumab with abiraterone acetate and prednisolone in patients who are chemotherapy-naive metastatic CRPC. So this is a non-randomized, multi-center, multi-cohort, open-label phase 1b/2 study of pembrolizumab-based combination. And in one of the cohorts, namely cohort D, the patients who were chemotherapy-naive were given pembrolizumab in the standard dose with abiraterone in the standard dose, and they will be assessed for safety and PSA response rate and the overall response rate. And this trial has concluded in the analysis done till now that there is significant anti-tumor activity and acceptable safety documented when this combination was used. The toxicity profile was, as is already known, for individual profile of each medication. One patient, however, did die of myasthenic syndrome. The PSA response rate was to the tune of 56%, and disease control rate was 44%. The result from this study of pembrolizumab with abiraterone acetate does support further need to evaluate this combination strategy in those who are chemotherapy naive. We are aware that before this, we had this Keynote 199 trial, which had used pembrolizumab with enzalutamide in a similar setting, chemotherapy naive metastatic CRPC patients, and found this combination to be efficacious in terms of tumor responses, PSA responses. The third strategy, combination strategy, is androgen receptor signaling inhibition with chemotherapy. And in this is an ongoing study, open label randomized phase 3 study, the CHARTED-2, which is studying the addition of cabazitaxel to abiraterone in metastatic CRPC after prior docetaxel failure. And the results of this study are awaited. The fourth combination treatment strategy is chemotherapy with IO. And what's the rationale for using chemo with IO is that taxanes such as docetaxel may have immunostimulatory effects by increasing the tumor antigen presentation to the immune cells. It could also be promoting the production of inflammatory cytokines and therefore could modify the immune response to the tumor. And therefore, the trials are investigating this combination of docetaxel with the anti-PD-1, PD-L1 agents because they have the potential to result in more effective immunoresponsive microenvironment. So Checkmate 9KD is a trial, one such trial, which is open label phase 2 study, studying the combination of nivolumab with docetaxel in chemotherapy naive patients. So they get up to 10 cycles of nivo with docetaxel 3 weekly, followed by nivolumab maintenance for up to 2 years or until progression of disease or unacceptable toxicity. And this would be interesting to note the results of. The other such combination testing trial is the Checkmate 7DX trial of nivolumab with docetaxel again. Herein, this is a phase 3 randomized trial, which is randomizing the patients into nivolumab with docetaxel versus placebo with docetaxel. The patients in nivo-dozi arm do end up getting the nivolumab maintenance as well, as was done in the earlier phase 2 trial, and the other arm gets the placebo maintenance. The results of this trial are also awaited. And we have this Keynote 365 cohort B arm, which is studying the combination of pembrolizumab with docetaxel. This is open label phase 1b2 study with pembrolizumab, and the efficacy outcomes of this have already been reported and found overall response rates with this combination to the tune of 23% with disease control rates of 73% in those who had measurable disease. PSA response was also to the tune of 27% in those with measurable disease. The last combination strategy under study is the combination of IO with PARP inhibitor. And this combination, again, has the potential for additive effect in those patients who have BRCA2 mutation and also have MSI high. There is a logic in combining PARP inhibitor with pembrolizumab. And the other patients who have non-BRCA mutations are also being studied, namely the CDK12 mutation. This is also under study. And there seems to be some potential for synergistic effect of this immuno with PARP inhibitor combination as well. And this is one very interesting phase 2 study, Checkmate 9KD, which is in fact a 3-arm study, one arm getting nivolumab with rucaparib, the other arm getting nivolumab with docetaxel chemo, and the third one getting nivolumab with enzalutamide, and it would be interesting to see the results. To sum up, this slide summarizes the various select combination strategies and ongoing trials. The bars in green show the phase 3 studies, some of which I've already touched upon, namely the PROPEL and the Magnitude, which were presented in last month in the ASCO-GU symposium. Some other immune checkpoint inhibitor combinations under active study, and the results of these study and the updated results from PROPEL would be eagerly awaited. So I would end my talk here, and thank you for giving me this opportunity. Thank you.